Well, good afternoon. I'm Chris Fanton. It's my pleasure to welcome you to our Asthma Grand Rounds program today. I'd like to take a minute before introducing our speaker just to share with you our program for next year. I won't read through it, but it's an outstanding series of presenters and topics, and it will include, thank you, clinical issues and basic science topics, adult and pediatric asthma, allergy and pulmonary issues. And in that way, I think it reflects the essence of our Partners Asthma Center. And I hope you'll join us for future programs. And also, we welcome your thoughts for topics and speakers for the subsequent years. Well, it's my great pleasure now to introduce today's speaker, Dr. Les Kobzik, and I'm delighted that he is here today to talk to us about what histopathology can teach us about asthma. It's been about 2 years. I've been very eager to hear this talk. Dr. Kobzik, as many of you know, is an outstanding pulmonary pathologist here at Brigham and Women's Hospital. He's professor of pathology at Harvard Medical School and professor in the Department of Environmental Health at the Harvard School of Public Health. And one of his many research interests has been the influence of maternal factors on the development of asthma in childhood using animal models. And we're delighted to have him here to talk to us about the role of pathology and the insights that pathology can offer in understanding asthma. Dr. Les Kobzik.
Well, good afternoon. Thank you very much, Chris. It's an honor to be asked to present at Asthma Grand Rounds, and I'm delighted for the opportunity. Let me tell the audience right from the beginning that Chris gave me a very specific set of marching orders for this presentation, and they're captured by the title, which is of his crafting. And I took it to mean, and this is what you're going to hear about, a review of very much a clinically centered discussion of the role of histopathology in clinical diagnosis and management, and whether and to what extent does histopathology contribute to present-day asthma clinically, and where might it fit in the future in terms of clinical research and identifying subtypes for better management. So let's try going forward this way. What I'll do in the presentation is I'll try to start with a review which recaptures what I often present in med school lectures, for example, as the characteristic of pathology of asthma, which will be a simple start, and it'll be somewhat wrong, but it's a good starting point. We'll spend most of our time talking about the concept of airway remodeling and the role of histopathology in establishing and questioning the definitions and the utility of that concept, starting with its initial promise and excitement and the limitations and complexity that we've become more aware of over time, and finishing with some discussion of where I do think there is a role for histopathology in evaluating airway remodeling as a part of the clinical management of asthma. There will be a small side trip in which, primarily to offer our wares from the pathology department, I will share with you, in addition to what we can or cannot do for you for asthma, there's a potential role for histopathology to help you exclude other diseases. And this will be a bit of a diversion, as you will see, but you're warned now. All right, so let's start with the basics and the so-called characteristic pathology of asthma. And we often begin by looking at the normal airway, illustrated here with a cartilage island, a small amount of mucus glands, inconspicuous smooth muscle and connective tissue, virtually absent leukocyte infiltration, and a regular normal ciliated epithelium and empty lumen. And this, of course, changes in the characteristic pathology of asthma, where we illustrate, and it's so abnormal I have to put labels on it to remind myself where I am. So here's the cartilage island, and here's the lumen full of mucus. In between, we have dense airway inflammation, increased vascularity, and remnants of epithelium that are actually partially interrupted and denuded, as seen in this strip right here. Going higher, we see the characteristic recognized eosinophilic airway inflammation identified by the numerous eosinophil granule-rich leukocytes present in this inflammatory infiltrate. We can step back and look at some other features. In some of these extreme examples, where we illustrate the so-called characteristic features of the pathology. Once again, the lumen is full of debris and mucus. We have evidence of increased smooth muscle. Handily enough, this biopsy came with arrows to help us find the smooth muscle bundle, but I think you get the message that they're really quite expanded compared to normal, or the normal that we saw a slide or two ago. When we get closer, we identify one of the features that pathologists for a century or two called basement membrane thickening, but we now have to add the air quotes because we realize it's actually not the basement membrane. Electron microscopic and other biochemical studies reveal that in fact the true basement membrane inside here is just fine, and there's a bunch of subepithelial fibrosis, collagenous elements, and other matrix elements opposed to the normal basement membrane. And leading to this thickening, but it is quite conspicuous and striking histologically, and certainly caught the imagination and has been part of the way pathologists think about what we look for in asthma biopsies for decades. Seen here as well is more of the eosinophilic and very dense airway inflammation. Another feature that's part of the characteristic package is, of course, mucus cell hyperplasia. So rather than a row of nice protein-rich pink cells labeled by eosin of the respiratory epithelium, there's a lot of interspersed gray-white cells, and those are the goblet cells or mucus cells, characteristically hyperplastic in asthma histopathology. And there's variation in staining and frequency, but these two samples show the same story. And to wrap up our tour of the so-called characteristic pathology, especially if this were the med school lecture, I would include these bits of trivia useful only for board questions and that have absolutely nothing to do with modern clinical practice. Some of the mucus, of course, spirals, and guess who named them? And you can see that in sputum. And the eosinophils release crystals, and this was a tag team effort, apparently. And we now know something a little more sophisticated other than their ruptured contents of eosinophils. There's actually crystallization of a specific enzyme. But these are features also present in sputum, but are not, as far as I know, part of any clinical practice for maybe 100 years. All right. So this characteristic pathology of asthma that we have reviewed is simple, it's very dramatic, drawn primarily from fatal asthma cases, lots of the abnormalities staring at you right in the face, very convenient for capturing the so-called characteristic pathology for teaching purposes, but it's primarily, it's more wrong than it is right. And the reason for that is that the real histopathology of asthma really differs in severity and heterogeneity. Let me give you an example. So among the reviews of airway modeling, people illustrate their points. And you can see here in this review, there are points to be made about normal or sample or biopsy from a moderate asthma patient or a severe asthma patient. And I think it's fair to say that these look, at first glance, pretty similar in contrast to the catastrophe I've been showing you as the characteristic pathology of asthma. And in fact, these workers, because they're interested in the epithelium and the lamina reticularis, a fancy name for the increased matrix that makes the basement membrane look thicker, it's so subtle that they actually have to put labels on it for us to be able to see it. And you notice the paucity of this so-called moderate asthma and severe asthma biopsy of those features that were flooding the fields in the characteristic story I shared with you a moment ago. So the severity, there's quite a bit of spectrum to it. And fortunately, most people with asthma don't have fatal asthma, which is what we use or have used historically as the characteristic milestones of asthma. In fact, most asthma is relatively well managed with 5 to 10% problematic subset. And those individuals, when biopsied, have much more subtle and distinct changes than commonly considered, quote, characteristic. Now, the heterogeneity point I want to illustrate by going back to one of the initial studies that started to think about whether structural changes could help inform problem cases in asthma. And this was a study from Sally Wenzel, who looked at a number of different subtypes of asthma defined clinically. And the ones she's really interested in are the problematic severe cases with very low FEV as a percent of predicted, as identified here. And by doing biopsies in this study, she then applied immunohistochemistry to, with more sensitivity perhaps, identify eosinophils by using the label EG2, eosinophil granule constituent number 2, and counting the number of eosinophils per unit space in these biopsies. And what she advocated on the basis of this data were that there are two subtypes of severe asthma, and that's highlighted in the large letters here. She found that, yes, there were some that had more eosinophils than anyone else, normal, mild, moderate, and she called those the eosinophilic subtype. But there was a subset that didn't have many eosinophils at all, and yet were severe asthmatics. This is the image that corresponds to that quantitative data. So in this column, we have labeling for eosinophils using that EG2 marker. In this column, we have labeling for neutrophils using neutrophil elastase as the target antigen. And so she identified these two subtypes, eosinophilic and neutrophilic. In eosinophilic patients, she observed eosinophils and some neutrophils. In the neutrophilic subset of severe asthma, in her cases, no eosinophils, plenty of neutrophils. So life was simple with two subtypes, but of course, medicine is ruled by splitters, and so is biology. And with more time, people have observed that, in fact, there are probably at least two other important subtypes. And depending on the study, you may encounter mixed granulocytic or paucigranulocytic. So in this case, in a later paper, she has included this grouping, as we'll see. This has a few lymphocytes, but really no granulocytes, either neutrophilic or eosinophilic. And these seem to be a separate subtype of severe asthma. And there are people who have mixed granulocytic. And in fact, in retrospect, if we go backwards, this eosinophilic individual would nowadays, in this clinical research arena, would probably be called a mixed granulocytic because, as you see, they have both eosinophils and neutrophils. So, in part, the characteristic pathology of asthma is elusive because asthma is a very heterogeneous disorder, as is more and more recognized. It's a big tent, and you can, as Dr. Wenzel has here, identify potential schemes for dealing with this heterogeneity by clinical or physiological phenotypes, and some of those are listed there, including the severity definition that's of interest, especially today. Phenotypes related to triggers, including exercise or specific environmental exposures, and at this point in her evaluation, the three histological subtypes, eosinophilic, neutrophilic, and paucigranulocytic, were options. That was 2006. Time passes, things get more complicated, graphics packages improve, and you can present the complications of heterogeneity in asthma in a graphic form in her recent review, just out this month in Nature, which captures the idea that there seems to be people who do exhibit many of the features of Th2 skewed inflammation. Inside that grouping, typically starts earlier. There are subsets that have aspirin-induced respiratory disease, true atopic disease. There's another cluster of people who have less evidence of Th2 linked to obesity, late onset, some other subtypes. And this is only one person's view, and you'll find different versions of this very complicated scheme as you explore heterogeneity in asthma. And the corresponding potential is that this could explain some of the variability and heterogeneity in histopathology. I think the mistake was mentioning environmental allergens. Okay. So, what I want to stop and consider now is how some of these concepts arose at the same time that the idea of airway remodeling came to exist and started being explored. Part of the story was, in fact, the rarity of the so-called characteristic findings. The large part of the story was recognition of, with more and more biopsies, of the complexity of airway inflammation, and with inflammation, the idea that wound healing should follow, and wound healing leads to remodeling or changes in tissue. And this leads to a couple of questions that we'll try to explore through the perspective of airway remodeling. Are there pathologic changes that can help us explain the cause or the progression of asthma, the pathogenesis? And mostly I'll focus in this clinically oriented session on, are there changes in airway remodeling detected by histopathology that can help guide clinical diagnosis, prognosis, and treatment? So we need some definitions, and we're in luck. There have been some committees at work. Here's one. Airway remodeling encompasses alterations in structural cells and tissues in asthmatic as opposed to healthy airways. You feel like you know a lot after that, right? How about this one? Structural changes involving the composition, content, and organization of many, not wanting to say how many, of many of the cellular and molecular constituents of the bronchial wall. If you fear that that's getting a little too specific, this author also includes the escape clause that, by the way, this also occurs in COPD, cystic fibrosis, IPF, and systemic sclerosis. So I think you can see that as people have learned, and these are more recent reviews, and in all fairness, they're excellent reviews, they're at the bottom, that the field has measured so many different things that it's very difficult to encompass in one very concrete statement what airway remodeling means to a given clinical investigator or community of investigators. In general, what people mean is what we started with, but in much smaller doses. So here's an example that is used to illustrate airway remodeling. The arrows point to epithelial changes and mucus hyperplasia. This arrow points to increased connective tissue in this zone of this airway biopsy. This arrow points to denuding of the epithelial cells, and this one points to increased smooth muscle mass, capturing many of the points that we mentioned already, but in a smaller, calmer version, I guess. So the defining features can be summarized as, in the epithelium, airway remodeling describes shedding, loss of ciliated cells, and mucus cell hyperplasia. In the so-called basement membrane, it's subepithelial fibrosis, excess connective tissue. This has some synonyms. Sometimes the strip is called the lamina reticularis, or the reticular basement membrane. The smooth muscle is increased in size, and that includes evidence for hyperplasia, more cells, hypertrophy, more size of the cells that are there. And there's also interest in the movement of cells after, say, epithelial mesenchymal transition or other alterations outside of the smooth muscle bundle into the smooth muscle bundle to add to that volume. Nevertheless, those are the main concepts there. And the vasculature is also remodeled or changed. There's evidence of new vessels and angiogenesis. Now, I'm not going to spend much time thinking about or discussing the extraordinary database and soup of cocktails and mediators that people know are part of the asthma story and are struggling to sort out in a useful manner. I will summarize here that many of the features that are captured by the phrase airway remodeling are in fact linkable to specific mediator and mechanistic molecular pathways.